Uh, it's my privilege, of course, to introduce Dr. Stack, who I think most of you know, and I am really excited to hear her present on this topic that, if many of you know me, I have railed about and tried to bring more awareness to. So I think having a presentation in a grand rounds presented by one of our esteemed fellows, who I think will do an amazing job bringing this topic to light for us, is really exciting and important, because as you know, I work at Harborview, and I think so many of our patients, not just at Harborview, but in many of the places that we work, come with a lot of history of medical mistrust, and that informs the behaviors that we see then in the hospital and the way that they interact with us and with the medical system. And so having some background on that and knowing what's behind some of that, I think is critical in the ways that we restore trust and try to provide the best care possible for our patients. So I'm going to let Dr. Stack take it away.
Thanks so much, Anna and Shanitra. And I will just start by sharing my screen. See, all right. Well, first I just want to say thank you so much for having me and for getting to talk about this topic. I think one of the great things about fellowship is you have the opportunity to learn new things and then see them immediately put into practice. And I think trauma-informed care is especially true of that. Rather than treating trauma itself, we're going to focus this presentation on how to practice trauma-informed care, and these examples are specific to the end of life. So, part of trauma-informed care is caring for ourselves, our patients, and our colleagues. And within that is recognizing that many of us have experienced traumas, and talking about trauma-informed care might be difficult to process. So while I appreciate people turning on their cameras to say good morning this morning, I want to actually invite you, and this is rare in our COVID Zoom area, but actually invite you to turn off your cameras during the presentation and then back on during the Q&A, just so that anyone who wants to process this information can do it privately, and feel free to do so. So I thank you for turning on your cameras, and I encourage you to turn them off just for this portion. All right. So I am going to start us with a case first, and then we'll use this case to put the information that we learn into context. So this is a real patient, but I've changed some of the information to protect her privacy. And this is a 34-year-old woman with metastatic breast cancer that was diagnosed 1 year prior to admission. At that time, when she was first diagnosed, she had declined cancer-directed therapies. So she presented to the hospital a year later with severe cancer pain and hypercalcemia. She was transferred from a hospital in the region to the VA Puget Sound for the intention of palliative radiation. But when she arrived, she actually declined palliative radiation and all care, including nursing care and even speaking with providers. But the one consistent thing that she said was, "Let me go, I want to leave." But unfortunately, she was unable to go back home because she had severe pain. So the team was unable to discharge her. For her social history, she was an Army veteran. She also had bachelor's degrees in criminal justice and security management. And yet she had been intermittently employed and intermittently unsheltered throughout her life. She had no social support in Seattle, where she was transferred to. The rest of her family was in the region. So she was basically here alone. For her past medical history, she had a history of diabetes, hyperlipidemia, chronic pain, tobacco use disorder, and alcohol use disorder. Our psychologist also evaluated her at the VA too, and noted that she had PTSD, for which she was 70% service-connected. Also histories of childhood trauma, military sexual trauma, and concurrent depression, anxiety, and irritability and mood issues. So this is a lot for one person, and I want us to keep her in mind, and we'll return to the case at the end after we go through a few topics. And what we're going to talk about today, first with what is trauma. So looking at definitions and frameworks for ways for us to think about it. And then we'll talk about its prevalence and effects. followed by how you can recognize trauma in your practice. And then we'll get to what is actually trauma-informed care. And I'll share some resources with you if you'd like to learn more after this presentation. So, given the association of trauma with substance use disorder, SAMHSA is a leader in trauma and trauma-informed care, and they've actually built the foundation for most of the information and training that we have on it. So they talk about trauma as individual, historical, intergenerational, or community-based trauma results from events, series of events, or set of circumstances that is experienced as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on an individual's functioning and mental, physical, social, emotional, or spiritual well-being. So when we think about this is a big definition, but we can actually simplify it into two frameworks when we think about trauma. The first are the 3 E's of trauma. The 3 E's are events, experiences, and effects. So we'll start with events. The focus on events places the cause on the environment. So it's not some shortcoming of the individual. And when we think about events, more typically we might think about abuse for someone who has experienced abuse, witnessed abuse, and that can be through persons, through institutions. Another event can be loss. So that includes death, abandonment, neglect, separation, natural disasters, terrorism, war. And then there's chronic stress. So that persistent fear. And that can come from poverty, for example, food insecurity, housing instability. It can be experienced through racism, invasive medical care, which we might frequently see in our practice. Community trauma, historical trauma, also family trauma, including substance abuse or mental illness in the family. So many type of events, but you can categorize them into these general 3. And then the next E is experience. So the focus on experience highlights the fact that each person's experience of trauma can differ. Trauma is a complex experience. It can be a single incident, but often it involves multiple complex situations that happen throughout an individual's lifespan. And so their reaction to an event might be affected by earlier experiences. And these can include, but aren't limited to, events one doesn't remember, like in early childhood, and events that are necessary, such as medical procedures, and events that happen to a group that one identifies closely with. And one example I put here is the genocide of Native American people. And then there's the effects of trauma. So we have events, experiences, and effects. Trauma can affect people in multiple ways. So coping responses, also mastery of developmental tasks. And, we tend to think about that in childhood, but there's also developmental tasks of adulthood that we might recognize in our patients. For example, achieving autonomy, establishing their identity, so their preferences, their likes, their philosophies, developing emotional stability, and managing a budget, maintaining a home. All of those are developmental tasks of adulthood. And trauma can also affect the ability to engage in relationships, physiological responses, which we can see manifested in disease, and psychological well-being and spiritual beliefs. I think talking about like a broad range of potential effects reminds us that, beyond symptoms and behaviors, our goal is to really support the whole person. And I think you can see within this list, there's important roles for basically the entire hospice or palliative care team here. So we have the 3 E's of trauma: events, experiences, and effects. Another way to think about trauma is also through the stress that people experience. So here's our second framework, just types of stress. So the first one out of 3 is a positive stress response, and these are often temporary. Positive stress responses are normal and essential parts of our development throughout life. For example, starting a new job, giving grand rounds right now. It can involve brief increases in heart rates, mild elevations in stress hormone levels. But the key here is that they're temporary. They either end or we adapt in some way. The second type of stress is tolerable stress response. So, the body's stress response here, it's activated to a greater degree, and it's due to more severe difficulties, for example, losing a loved one. But the key here is that the body can recover from what would be damaging effects if you were activated longer. So here the activation is time limited. And what research has found is that it's also buffered by supportive relationships that help that recovery. And so the keys here are time limited and having supportive relationships. And so this third type of stress is what tends to lead to trauma. This is a toxic stress response. It's prolonged activation of the stress response in the absence of protective relationships. So you can think of this as prolonged adversity, for example, indefinite food insecurity, or compounding stressors. So the things that can come along with substance abuse. And the prolonged activation can disrupt brain architecture, the immune system, and other organs, increasing the risk of stress-related disease or cognitive impairment. And so an example within that are the delayed developmental tasks that I mentioned earlier. And we'll get a little bit more into the science later in this presentation too. And so that's our introduction to thinking about trauma. We've set a definition here from SAMHSA as circumstances experienced as harmful or life-threatening with lasting adverse effects on functioning and well-being. And we've learned a way to think about trauma in two different frameworks. So trauma in terms of the 3 E's, events, experiences, and effects. I'm also thinking about trauma through 3 types of stress: positive, tolerable, and toxic. So now that we've defined it, let's move on to talk about the prevalence of trauma and the effects that we see. It's hard to talk about trauma without talking about ACEs, which are adverse childhood events. So what we know about the long-term effects of trauma actually come primarily from studies of ACEs. And what I'm going to refer to here is the first one from 1998, but I'll also say there's been many after that that have updated numbers and what we know about disease effects. But I want to show you the basis of where this came from. So the original ACE study was in the mid-90s, and it was a partnership between the CDC and Kaiser. And they surveyed over 17,000 adults that were coming in through their primary care clinic in San Diego. And they surveyed them on trauma histories based on this conceptual framework that you see here of how ACEs might influence health and well-being throughout the lifespan. And so starting at the bottom of the pyramid, adverse childhood experiences, postulated to lead to social, emotional, and cognitive impairment, which can lead to adoption of health risk behavior, and leading to disease, disability, and social problems, and the potential of early death. The ACEs that they studied were defined in 3 big categories: abuse, neglect, and household dysfunction. And so within abuse is physical, emotional, and sexual. Within neglect is physical and emotional. And then within household dysfunction is mental illness, mother treated violently, divorce, incarcerated relative, or substance abuse. I want to take a minute to show you the population that was being studied here too. You'll see it was primarily white, almost 75%. The largest age group was 60 and over, about 46%. And then the majority, so more than 70%, had some college education, if not finishing college or higher. So a group that we would typically think of as having some privilege in society. And what we found was a very high prevalence of ACEs, or at least high to me. I was quite surprised. So, within the abuse category, 28% had reported physical abuse, and nearly 15% reported emotional neglect. And then within household dysfunction, there were nearly 27% for substance abuse, 23% for divorce, and then nearly 20% for mental illness. So I'll say these were higher than I had expected. And I think at the time, they were higher than the authors had expected as well. The other interesting thing about this, in addition to the prevalence of each type of ACE, was actually the prevalence of multiple ACEs. So among the entire population, 67% had at least one adverse childhood event. So at least one trauma. And so that's 2 out of 3. And then looking at 4 or more ACEs, 1 in 8 of the population had 4 or more. So we can see that multiple ACEs were actually quite prevalent. The other part of the study they looked at was the risk of increasing ACEs with disease. And they looked at several, and it was really interesting. As you increase the number of ACEs, so does the risk of multiple diseases. So here, what you're looking at is a table for smoking. And as the number of ACEs increases, the odds of smoking increases. So by the time you get to 4 or more ACEs, your risk of smoking is more than 2, or the odds ratio of smoking is about 2.2. You're also 8 times more likely to have alcohol use disorder, 10 times more likely to have reported injection drug use with 4 or more ACEs, and more than 12 times more likely to have attempted suicide. The other part of this too is that ACEs dramatically increase the risk of 7 of the 10 leading causes of death in the United States. And so you can see here for conditions like severe obesity, diabetes, and skeletal fracture, more than 1.5 times more likely if you have 4 or more ACEs. For ischemic heart disease or any cancer, pretty much twice as likely. Stroke, hepatitis, jaundice, sexually transmitted infection, about 2.5 times as likely. And in this study, your chances of having chronic bronchitis or emphysema were 4-fold. I'll say these numbers have changed a little bit, but not too far off from what was originally found in this study. And the other part of this too is that the average lifespan was about 20 years less if you had 4 or more ACEs compared to none in this study. So I think now is a good time to ask, why does this matter at the end of life? There's a couple of things, and I think maybe with this audience, you all know this well. The definition of trauma includes circumstances that are life-threatening, which is also a requirement for hospice. Being at end of life, you need a terminal illness. And the other thing too is that normal aging includes life review. So this can be with aging, but also as people approach the end of life, no matter what age. And that can include integration of past traumatic events. For example, symptoms emerge later in life related to early life war zone trauma and aging combat veterans, which is where most of this work has been done. I want to show you a recent study in the past year that looked at how veterans experience distress related to past trauma exposure as they near the end of life. This was a study of 10 focus groups with hospice and palliative care clinicians who provide care for veterans. And what they found was 85% of veterans have experienced trauma within the population they were caring for. And those with trauma experience or trauma exposure experience greater trauma-related memories and PTSD symptoms as they near death. And what the clinicians observed and the behaviors in the population were actually consistent with re-experiencing traumatic events. So that includes the veterans were having intrusive memories, nightmares or very vivid dreams, flashbacks or dissociative reactions, and psychological distress in response to trauma reminders and cues. And a lot of them were re-experiencing this in tandem with dementia or delirium. So these authors uncovered more evidence of the importance of training healthcare providers to care for veterans with PTSD during the dying process. But I might say really anyone with any trauma that they've experienced in life who are experiencing the dying process. What they also found was that the veterans might fare better if they had opportunities to talk about their traumatic experiences and find meaning in them. Reconciling the good with the bad. And this is a technique known as later adult trauma re-engagement, or LATR, which is used by psychologists to help in this situation. So we've talked about trauma and we've talked about its prevalence, and that 2 out of 3 people have experienced some form of adverse childhood event. And we've talked about the effects that we see, the associations with health risk behavior and disease. And so the next question you're probably wondering is, how do I recognize trauma in my practice? So there's 4 ways that I want to put forward to you that I learned from CAPC. The first is assume instead of asking. We found that a lot of people, the majority, have experienced trauma in some form. And so approaching patients with a trauma lens that assumes adversity may have contributed to their current illness and coping behaviors. Regardless of whether a patient chooses to disclose their trauma history, referrals can be made to interventions that address experiences and consequences of past trauma. So kind of presuming that the population that's coming in has experienced something. And the next option is using open-ended questions. So in your history taking, allowing patients to disclose any form of trauma they feel is relevant to their well-being. And this is one example I came up with, but I think there's many ways to do it, depending on your comfort and what your interaction is like with the patient. So one way is difficult life experiences, like growing up in a family where you were hurt or where there's mental illness or drug or alcohol issues, witnessing violence. All of these things can affect our health. Do you feel like any of your past experiences are affecting your physical, emotional health? And kind of inviting them to share if there are things that they feel we could do for them, without necessarily having to re-experience the trauma or share that, but to share, yeah, I feel more comfortable if I have clear access to the door during our exam. The third option is using a structured tool. And I'll say this is an option that needs to be done with support. So there's multiple validated scales that exist for screening for past trauma. And I'll say most of them that I saw were actually related to PTSD. But this one, the life events checklist, is a general list of things that people may have experienced, whether or not PTSD is present. So the caveat to this is if a structured screening tool or process is used, you have to consider when, how, and who will administer it, as well as who will have access to the information, because it's something that needs to be done with some knowledge and training. And the other part too is that if the tool is used, it's important that the patient is able to discuss their responses with the provider in private, and because this will have brought up things for them. And here's a little snapshot of the life events checklist, which you can actually access through the VA website. The fourth option, I think, is something that I tend to favor. It's screening for the impacts of trauma rather than the trauma itself. So, thinking about common conditions that are highly correlated with traumatic experiences, we've seen a lot that were already associated with ACEs. And there's other literature that shows that trauma is associated with, as expected, anxiety, PTSD, depression, and suicidality, and also substance use disorder, chronic pain, and morbid obesity. And these are separate studies from the ACE studies, but confirm that as well. And these conditions are often markers for past trauma, and they benefit from being addressed in a trauma-informed manner. Other signs of trauma that you may see in your patients, excuse me, are hyper-awareness or exaggerated startle responses. For example, when you walk in the room, do they seem startled? Sensitivity to noise and touch, reporting intrusive memories or nightmares, or even if you ask them about it, having difficulty concentrating, confusing what is safe and what is dangerous. So for example, nursing care, not being sure if that is a safe situation or dangerous. Irritable or aggressive behavior, risky or destructive behavior, blowing up when corrected, so having some volatility, resisting change, difficulty trusting, and emotional swings. And these are all signs that your patient may have experienced trauma and would really benefit from a trauma-informed approach. So I want to show you some examples of what that could look like. This is a person who was a 29-year-old man with metastatic anal squamous cell carcinoma and AIDS who was presenting for end-of-life care. In his presentation, he required frequent pelvic wound care and cleaning, and had physical signs of pain, but was minimally responsive to voice. And his visitors included his sisters, parents, and step-parents. So I want to highlight the potential of trauma and its potential impacts. This is a young man with cancer and a sexually transmitted infection leading to AIDS. So, these are things that have been associated have a higher risk when you have multiple ACEs. So in his care, I think one of the things, or a couple of things that we would pay attention to are asking permission and verbalizing what we plan to do, especially prior to pelvic care. And I'll say that is even with him being minimally responsive to still verbalize those things. And the other tip too is thinking about stepping out of the room for difficult conversations with family. And again, even though he's minimally responsive, there might be things that he's taking in that we don't want to add to trauma, or that he might be feeling anxious, even though we can't see it. Another example, this is a 30-year-old woman with a history of anxiety who presented with a left tibia fracture after a motor vehicle incident. She underwent an intermedullary rod fixation. And on hospital day 4, the pain team was paged frequently throughout the night. And the patient had woken up crying loudly in pain, was inconsolable for hours despite repeat clinician boluses from her PCA. I want to say this was an interesting case because on the APS team, there's also a psychologist who pointed out her history of anxiety and that the events of the previous night were likely due to vivid nightmares after experiencing a traumatic event. So in her care, we would pay attention to recognizing her anxiety, but also this recent trauma in addition to her pain. And then my last example, and this is a 74-year-old Vietnam veteran with metastatic lung cancer at the end of life. He was diagnosed with PTSD about 40 years ago and had remote alcohol use disorder in remission. He had a master's of business administration, was a retired hospitality manager, and no other medical diagnosis until his cancer diagnosis 1 year ago, for which he underwent chemotherapy. And at the end of life in hospice care, he appeared in pain, but declined all pain medication, saying he never took medication until chemotherapy. And so, there are some evidence here that he's experienced trauma and has the effects of trauma. And so when the team psychologist evaluated him, he shared that he was experiencing intrusive thoughts, nightmares, and hypervigilance. And so again, we know as veterans age, they may experience an emergence or exacerbation of stress symptoms, especially as life review occurs. So this was the ideal patient to do later adult trauma re-engagement with. Great. So we talked about trauma, its prevalence and effects, and we've talked about 4 ways to recognize trauma in your practice. Assuming people have trauma, that everyone who comes in will have trauma, asking open-ended questions, using a screening tool provided you have the resources, and then just looking for the signs and effects of trauma and using that to guide you. And so the next question is, what is trauma-informed care, or what do we do next once we have this information? And I want to take a minute and step back before we get into the details of trauma-informed care and share this with you. Imagine a world where we interact with every life we meet as if we knew their story of hardship and trial, and we engaged with them from that knowledge. I think this is the essence of trauma-informed care, and I'd like us all to keep this in mind as we go through the specifics. So trauma-informed care is actually an organizational approach, and we'll talk about our own individual approaches, but I want to put it out there that it's actually across the spectrum of an organization. And it's an approach to care that assumes that everyone who encounters the system might have had a past traumatic event, and seeks to ensure that they avoid re-traumatization. The approach is critical in end-of-life care because past trauma plays a role in how people react to and cope with pain, terminal illness, and loss. And this information and a lot of this presentation is informed by the National Hospice and Palliative Care Organization, which has a good toolkit on trauma-informed care at end of life. And I'll show you that resource towards the end. So a trauma-informed practice abides by the 4 R's. It realizes, recognizes, responds, and resists re-traumatization. And I'll share these briefly with you because it's the foundation for the principles of how we practice trauma-informed care. So realizes the widespread impact of trauma on family, groups, organizations, and communities, as well as individuals. And realizing the impact, people's actions and behaviors are understood in the context of coping strategies. These are things that they've done to survive adversity and overwhelming circumstances. But the other idea too is that trauma-informed care isn't excusing or justifying behavior that's unacceptable. It's understanding why it's occurring so we can respond accordingly. So number two, recognizing. So recognizing the signs and symptoms of trauma in patients, staff, and providers within the system. So I want to make a key point there too, that we're looking at patients, but we're also evaluating in ourselves and our coworkers as well. Because a key concept in trauma-informed care is that workforce wellness is a really important piece. The third part is responding. So response by fully integrating knowledge about trauma into policies, procedures, and practices. And the key part of that too that I find is seeking to actively resist re-traumatization. So understanding that people have gone through these things and seeking to not have them relive it in our care. So the way that we respond is by incorporating these 6 principles of trauma-informed care. And this is the crux of all trauma-informed care. If you remember anything, it's these 6 principles. They can make a significant difference to survivors of trauma. And in general, I think you'll find they just feel like the right thing to do, frankly, for all our patients. And the 6 principles are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. So we'll go through each of those and I'll give you examples of how you can incorporate them into your practice. So for safety, patients, staff, and providers need to feel safe. Safety is a necessary condition for healing. And so making sure that the physical setting is safe and interpersonal interactions also promote a sense of safety. So things that you can do in your practice, thinking about is the language used that ensures patients feel respected and supported from the moment they enter your clinic building or the moment you enter their home. Offering sufficient notice and preparation when changes are necessary, and remembering that some of the effects of trauma are having difficulty with change and not feeling that safety with knowing what to expect. Another example, giving patients clear access to the door so they can easily exit if desired. Asking your staff too, because safety is important for our physicians and providers and staff. Do direct care staff feel safe entering a patient's room or home? And for patients who are not alert, keeping noise levels low, avoiding having upsetting news programs or violent shows on television, asking family members to have difficult conversations out of the patient's earshot, so that there's a sense of a safe environment where they are. I'll add, this was a good tip shared with me, that whether patients are at home, a hospital, a nursing facility, wherever they are, that space is their home in that moment. And that's a space that we should respect and help to promote a sense of safety. The second principle is trustworthiness and transparency. So decisions should be made with transparency with the goal of building and maintaining a relationship of trust between patient and providers. And thinking about this, naturally it seems important, but thinking what people with trauma may have gone through, and fragile patient-provider relationships could stem from traumas that include betrayal from trusted caregivers. So for example, abuse at the hands of a parent, teacher, coach, etc. And fragmented medical care may stem from traumas that include betrayal from institutions and systems, for example, healthcare facilities, the military, government. So the questions to ask yourself, among others, are: do families trust staff to show up when they say they will and deliver the services promised? And the other part of this too, which I found in the training I did to be a pretty frequent concern, is when patients report symptoms, do the providers trust and validate that the patient knows themselves and their symptoms best? In other words, do they believe what the patient is saying, that what they're experiencing? Because in prior traumas, they may not have been believed or believe that they would be believed. So this is a really key point in building trust with your patients. The third principle is peer support. So peer support and mutual self-help are key ways to establish safety and hope, build trust, enhance collaboration, and use that lived experience to promote recovery and healing. So here in this situation, peer actually refers to individuals with lived experiences of trauma. But things that we can do to help promote that, we can provide validation of their experiences. If something is shared, to say that sounds really hard, and to really validate that. And also keeping referrals to peer groups and educational material readily available to all patients who disclose a trauma history, or even those who don't, having things in the waiting room. I've noticed our oncology wards tend to do this well, because I've noticed a lot of booklet shelves in the hallway that have information for support groups for patients and loved ones, and even some material that includes writing from patients who are going through, or patients who have gone through those experiences. The next principle is collaboration and mutuality. And so this is a key one. It's partnering and leveling power differences in the patient-provider relationship to create meaningful sharing of decision-making. And what that principle facilitates is healing, recovery, and resilience. And if you remember, we talked about trauma as having the potential effect of impairing developmental tasks. And part of that is building autonomy within yourself, and that includes resilience. And so one of the key ways that we can help with this is asking every patient when you meet them, what can be done to make them more comfortable during the visit or the hospitalization, giving them some collaboration and making sure that the both of you can work together in an environment that they feel comfortable in. And respecting their boundaries by explaining what you'll be doing and asking permission before you do it. So for example, before examining somebody, wound care, cleaning, etc. And making care planning a collaborative effort that includes all levels of staff and the patient and the family. So, collaboration, it's with the patient and providers, but it's also with everyone on the medical side too. And so we're really including a whole picture. And the fifth principle is empowerment, voice, and choice. And so patients are supported in shared decision-making, choice, and goal setting to determine the plan they need to heal and move forward. And the key to understanding this part is traumatic events can involve power imbalances that really take away an individual's voice, and can result in coercion. And so experiencing those things takes away empowerment, voice, and choice. And so being able to give that back to somebody in their care can be really helpful and productive. And so respecting and honoring patients' decisions, even when you disagree. Our patients and families offer choices about when, where, and how services are provided. And asking permission before doing things like sharing hard information, or calling a patient's family member when you didn't actually ask them if that was okay. Asking permission for examining the patient, etc. I think not valuing the patient's voice and decisions about their body, about their disposition, or about where they're going to be discharged to, it can be re-traumatizing because it takes away a piece of that part of them that was lost during their trauma. And finally, cultural, historical, and gender issues. And this is a broader picture that I think has been more apparent in the past few years, and actively moving past cultural stereotypes and biases. So challenging what we think about groups of people, recognizing and addressing historical trauma, and responding to the racial, ethnic, and cultural needs of patients, providers, and staff. So examples within this are recognizing the challenges people have faced and continue to face in our society is important for preventing isolation and humiliation in an individual's care. So for example, the pandemic has taken a disproportionate toll on Black and Brown people, and amid significant loss in these communities. How is this going to affect the perspective of the patient you're consulting on today for dyspnea? Another point is reflecting on your own trauma history and how it may influence patient interactions. And then the third one is reflecting on your own stimulus value and how a patient might react to that. What power and privilege do you reflect, whether intentionally or non-intentionally, in a system that may have caused harm to them, their communities, or their ancestors? An example I see not infrequently is a room of providers who are all white caring for a patient of color, and thinking how might this appearance or this setup affect the patient's experience of care, and what can I do to mitigate that? So these are 6 principles of trauma-informed care, and I'll say the crux of this whole presentation, thinking about how you can incorporate safety, trustworthiness, peer support, collaboration, empowerment, voice and choice, and cultural, historical, and gender issues into your practice. And so we've covered quite a bit. We've covered what is trauma, its prevalence, which is high, its effects, which we see. How do we recognize trauma in our practices, and what is trauma-informed care? So I want to take all of that information and bring us back to our case and see how we can take a trauma-informed approach to it. And so I've gone back and highlighted a few sections here that we could characterize in terms of signs of trauma. So we have this young woman who was diagnosed with breast cancer a year ago, declined cancer-directed therapies, palliative radiation, nursing care, speaking with providers, wants to leave, unable to discharge due to severe pain. I think thinking in terms of what we've discussed of signs of trauma, we could categorize these as destructive behavior for declining therapies, perhaps, irritability, resisting change, and difficulty trusting. And there's likely other layers within here that you can see too, but these are the ones that came to mind as I read this. We also see she's an Army veteran, and we know there's a high prevalence of trauma among veterans. We saw a statistic of 85% in a recent study. And we also see chronic toxic stressors, unstable employment, unstable or intermittently unsheltered. And we also see that this person is alone. They don't have social support where they've been transferred to. So, we also see she's got multiple traumas, both from the chronic stressors, but also this childhood trauma, MST, which contributed to the PTSD, depression, anxiety, and mood issues. And remember, if we think about her traumas in terms of what we know about ACEs, her risk of chronic disease is very high. And we see them here. In a 34-year-old, we're seeing cancer and diabetes and chronic pain. We know that people with 4 or more ACEs have a higher likelihood of, or twice the likelihood of smoking or having cancer, and 8 times more likely to have alcohol use disorder. So the team psychologist saw this patient or reviewed the chart and made some recommendations. And among them were no male providers, limiting contact to 1 female provider over a longer than normal work period to build trust over time. And so this is actually a hospital has very generously worked beyond their 7-day shift to provide continuity for this patient. And being cared for by the same group of female nurses to help them get to know each other and build some trust. And the nurses were encouraged to provide lots of listening and support and use distress tolerance skills or remind her of them, such as holding an ice pack, having 5 deep breaths, progressive muscle relaxation, which is PMR, and then things like counting to 10. And so if we think about these recommendations in terms of our 6 principles of trauma-informed care, we see a dedication here to safety. She would not feel safe with a male provider. And we see there was a gender issue in her history as well. And so we're addressing these 2 principles by limiting her care to female providers. We also see trust and transparency. The hospitals took the extra effort to build that trust with the hopes that it would pay off later. And then we see collaboration and mutuality. And with this group of nurses that was assigned to her, there's some dedication there to working together to help her cope while she's in the hospital. So after 2 weeks of this strategy, they had built trust, and the patient agreed to work with psychology. And while working with psychology, what they found is that the fear of taking pain meds was recognized as related to her prior traumas that she'd experienced and the result of losing her power, choice, and voice. So after 1 month of working with psychology on post-traumatic growth, after being able to recognize and share these things, she agreed to meet with spiritual care for psychosocial support and the palliative care nurse to discuss hospice. So she became more open to working with the team. And so thinking about our principles again, we've built trust and transparency. We've recognized the reason why she didn't want to take pain meds. She wanted to keep her mind as alert as possible to prevent these re-traumas. So having difficulty seeing what is safe and what is dangerous. And so giving her empowerment, voice, and choice in that. And then collaboration and mutuality. So working together at her pace to sort through what she needed to move forward. So at the end of life, she had built strong working relationships with nearly all her providers. And remember when she was first admitted, she didn't want to talk to anyone. And she even had close, healthy relationships with multiple members of the team. And her communication wasn't perfect, but it was definitely less volatile. And then the team's distress decreased over time as they better understood her perspective and how to interact with her effectively. She was also able to be cared for and express her needs to a male nurse and a male physician who she built a healthy relationship with. And she was able to build the trust to accept pain medications and build the post-traumatic growth to accept that as well. And in the end, she had a peaceful death without suffering nor distress. So in this case, we see how applying principles of trauma-informed care, despite initially seeming very difficult to do so, really paid dividends in terms of the patient's care and also the team's distress. I'll add too that if you didn't already appreciate the care and dedication of our VA colleagues, well, there you go. It's pretty fantastic. So I want to just briefly cover a few resources to share with you if you're interested in learning more or curious where some of the science comes from, and then we can open up to questions. The first resource I want to show you is the National Hospice and Palliative Care Organization website. They have a toolbox for trauma-informed end of care. And I'll say this is more a list of links and documents that explain how some hospice organizations have incorporated trauma-informed care, and also links to things like SAMHSA resources. I also want to point out the SAMHSA resource. SAMHSA has provided foundational material on defining trauma and trauma-informed care, and that many of the training modules on this refer to. And they have a document that explains all of this in detail as well. It's the concept of trauma and guidance for a trauma-informed approach. Also, this is the training module that I did to learn about the foundations of trauma-informed care. It's free through the Washington State Healthcare Authority. It takes about 2 hours unless you're taking copious notes, but it's really nice and engaging. And there's a lot of patients who come or give videos within the training to give their personal experiences, which really puts it into perspective. And then this is a great primer on ACEs. It's a TED Talk with Dr. Harris, who's the current Surgeon General of California. But it talks about ACEs and their physiological effects. She is also the founder of the Center for Youth Wellness, which houses many things, including policy papers, data on ACEs and toxic stress and the science behind it. And they also share a multidisciplinary model that they put into practice for addressing ACEs in their community. And so I think although this is addressed towards kids, I think a lot of this is very relevant to our adult population. And finally, the CDC has a really helpful section on violence prevention. And within that, it includes all the study on ACEs and outcomes, because if you remember, they were the original collaborators. Also violence prevention and coping with stress. And so we've talked about trauma, prevalence, and disease. How do I recognize trauma? What is trauma-informed care? And resources where you can learn more. And I'll just give a brief summary, which is if you take away anything from this hour, it's that at least 2/3 of your patients have likely experienced trauma. And that's in childhood alone, because of course life continues. Symptoms related to prior traumas can reemerge at the end of life. And we can uncover a history of trauma and respond to that without re-traumatizing the patient. And finally, I would just encourage you to think more about how you would incorporate these 6 principles of trauma-informed care into your practice. And then here we go. All right, and then I'm happy to take any questions, or even if there's anything you'd like to reflect on too, I would love to hear your thoughts. It's nice to see so many faces here. Thank you.
Shobha, hi, this is Josie Amory. Thank you so much for that presentation. Bessel van der Kolk, who wrote The Body Keeps the Score, he says that trauma shows up not as a memory, but as a reaction. And so I really appreciate what you were saying about assuming the presence of trauma and looking at it from behaviors. I guess given that, and also the high likelihood of trauma within our population of caregivers, I was wondering if you could reflect on sort of our own personal journeys of coming to terms with what we might not think of as trauma, but in our own reactions and in our institutional reactions, what that might be like.
Oh yeah, gosh, Josie, what a wonderful question and point to make. I have read in the past, and I wish I could remember where this comes from, but that a lot of people who go into medicine, maybe anecdotally, have done so out of some trauma maybe that they've experienced in the past as well. And I'll say, whether that's among doctors, among social workers, among nurses, there's some element of care in there that could be higher in our population, but I can't say for sure. I think an important part of this too, within trauma-informed care, is reflecting on how we're reacting to people. When the patient example that came in of saying, I don't want to talk to anybody, leave me alone, and the volatility of that, thinking about what is your reaction to that volatility and why? And because the initial thought is, well, of course I'm upset that someone's yelling at me. But thinking about your own stress response within there too, and asking yourself, well, why am I upset? Is there more? Because a lot of times there's a lot of layers that we may not even realize ourselves. And I'll say we may even recognize it in our colleagues before they recognize it in themselves. And that can be a hard thing to share, but it's important to care for each other as well. I wonder if anyone has any comment to that, thinking about how we react to our patients and our colleagues in the setting of our own traumas, and how to recognize that.
I think it's easy to get defensive and try to operate on a level of explaining the rationale, which isn't really the level that they're operating on. They just want to feel safe and heard and not be talked at. So I think that can be an easy response as a clinician.
Yeah, absolutely. That was beautifully put, Lisa. Thank you.
Yeah, that made me think about just how it's possible for us to sort of, in some senses, like, this is probably too strong of a word, but like punish our current patients for past patients that the case caused moral distress for us. And I see this a lot where, the family, the team are at odds about the right path forward, or components of the team. And we're sort of already jumping to like the worst case scenario about how this could drag out in a way that we saw in a prior case. And that, I think I've never labeled that as a trauma response, but could be one to think about too.
Amy, I see a lot of head nodding, and that really resonates with me too. The, oh no, I know how this is going to play out, even though we haven't necessarily given it a chance. So we haven't recovered yet from that experience. I'm seeing some interesting comments in the chat here. Transference and countertransference in relation to our own past traumas. Absolutely. And there was an article in CAPSI just last week about evaluating our own countertransference with patients too. That I've yet to read, but I feel like it's important after learning about this topic. Defensiveness is the first act of war. Yeah. I like that. I can see that relating to how we respond to patients. When does the provider find out about past trauma? Do they have to dig through chart notes perhaps years back before meeting the patient, especially if they're not English speaking? Oh, that is a good question.
That was my question. So my name is Rose. So I work as a cultural mediator at 4 different clinics. And I'm just wondering, I'm just taking a big step back. When do people find out about this? When do the different providers, they rotate through so many providers. And if the person's not English speaking, they're struggling to understand who's my doctor. Very simple things like who's your primary care provider? I don't know. It's whoever I happen to be seeing maybe 3 times a month or 3 times a week, depending on the state of their illness. So I know we're talking about, by the time they get to palliative care, but when they get referred, they have that referral and that, hour-long visit where you're sitting down and trying to mediate culturally, trying to get this very hard concepts to grasp. When does that provider, or do they go back 5 years in the chart or 10 years in the chart to learn what happened to this patient? Did they come from, X country? Did they serve in the military? Have they been homeless for 5 years? Were they, have they been, I mean, that might pop up in the chart, but have they been in a psychiatric unit? I mean, when is the point that any given provider will find out about these past traumas, given that everyone's got limited time? I mean, I can think of a patient who recently passed away just 2 days ago in palliative care. And I'm just thinking about this conversation, wondering how much did those palliative care providers even know about his, his past? And then there was a whole thing about someone putting a hex on him. And then there was some other violence in the home. I mean, it was just so long and complicated. So I don't know when do people find out? Sorry for the naive question, but just coming at it from the interpreter, cultural mediator point of view. Yeah,
Absolutely. No, I don't think that's a naive question at all, Rose. I think it's so important. And I want to defer part of this maybe to our Harborview colleagues who might have more experience with patients with limited English proficiency or in the international clinic. But what I want to add before I do is, there's I think one of the best approaches, especially maybe with limited time or limited communication, is looking for the signs and symptoms of trauma, whether in behavior or what they're presenting with, to give you a hint that maybe this is something that someone has experienced. Like, is this person jumpy when you walk into the room? Do they feel anxious or volatile? Are they having a difficult time with challenging information? What kind of support is there with them at that moment, and how are they reacting, to get an idea of relationships? I think there's hints that are important for us to look at with every patient, because you're right, we may not know. And I think the other thing too is people may not want to disclose that to us just yet, or they may not feel comfortable with it. Sorry, I think I'm seeing some answers here in the chat too. I wonder, or Dr. Hazen says, I wonder if it's not so important to know all of their story, but to be able to identify and be a way that they're, or identify the way they are exhibiting trauma language and behavior. And I wonder if anyone has anything to add to that too. I know we have a lot of people experienced. And I see, so true. I think we should be approaching all patients in a trauma-informed way. I think Rose, with some of the silence on that in our group right now, shows you that that is a hard question. And a lot of this, we might have to depend on the trauma lens for all of our patients. I see we're in a roll. Oh, sorry, go ahead.
Well, I just wanted to add, because thinking of this one particular patient who just presents so calmly, such a sweet guy, you know, they're not combative. I mean, certainly a lot of people are, but some people aren't combative and they're not jumpy, and
Yeah.
you know, it's just the what happened to them in their whole life. Yeah.
Yeah, I'm seeing a comment from Josie here. People pleasing is a trauma response.
Thank you.
Yeah. Oh, that makes it complicated.
I'm having a hard time articulating a question. Maybe it's a question for Josie, but I'm just reflecting on how in doing years of primary care, these kind of patients would be those sort of what we used to call heart sink patients, you know, they're sort of labeled as difficult sometimes, and you see them on your schedule, it's hard to gear up for seeing them. You feel that pushback from them in how to care. I'm just wondering about this concept of self-soothing before meeting these people. Does it concern more about that, or how one does that?
Grady, I'm so sorry. I could only hear part of that, but I heard the question was self-soothing.
Sorry, mic problems. How do people do that?
Is this any?
I think the question might have been, how do people do self-soothing? Is that right?
Yes.
Yeah. You know, I defer that question to one of our social workers or psychologists on the call. I think that's a great question, because the part of the key in the case we discussed was that Hallie Newsom, the team psychologist, was able to share these self-soothing techniques with nurses to encourage the patient to do.
I'm not a social worker or a psychologist, but I did put in that question about self-soothing and the importance of self-regulation, so that we can be the calm presence that is then capable of safely co-regulating with someone who is feeling dysregulated. And it gets just back to the idea that again, trauma is not a memory, it's a reaction in our body, and it's a heightened state of being in either a sympathetic arousal in terms of fight, flight, freeze, or appease place, or it's in a dorsal vagal collapse place where we've completely withdrawn and are numbed out and isolated and retreated. So coming back to kind of what we think of as a ventral vagal calm, rest and digest place. I think many of us as clinicians, we actually live for long periods of time in the activated sympathetic arousal place. So consciously learning how we can bring ourselves back to a calm ventral vagal. And there are lots of different exercises for that: breathing exercises, mindfulness, physical embodiment, lots of different, but making it a conscious practice and recognizing when we are in that sympathetic activation so that we can center ourselves and then be a safe presence for others who are feeling dysregulated. Thanks.
Thank you, Josie. I appreciate that. And I appreciate that question, Grady. I understand it now about self-regulating ourselves in difficult situations. I'll add too that one thing I found helpful is there was this mindfulness class that I took, and one suggestion they gave was before you step into the patient room, take a deep box breath for yourself and think about what am I like, really be present in yourself and in that moment before you step into the room and take on someone else's condition.
This is a different way to approach sort of self-soothing, but I'll add that reflecting with other providers beforehand. Like yesterday, I was messaging with an OT who was going to see a new patient of mine, and just sort of discussing how difficult it was to see this patient and caregiver, and being able to bond over that. So then we can both go into it again with more presence with the patient, because we've been able to debrief about it.
Thank you. I do find those times when we pre-meet to be so helpful. I'm seeing, sometimes I touch my heart and say to myself, there is enough before I walk into the room. Yeah. A nice way to be mindful of ourselves before we move forward. And well, we're super over the hour, and I want to be respectful of everyone's time, but I would just love this conversation and the questions that you posed. So thank you. I wish we had more time to do more, but I appreciate you all being here.